In this session, we will discuss briefly about this aortic regurgitation. So, all of the students are requested to ask and interact with our experts. If you have any kind of doubts, any kind of queries, you can straightforward ask and you can get a benefit out of it.
So then moving on to aortic regurgitation. Aortic regurgitation is another condition in which there is a long asymptomatic period. That a person can have aortic regurgitation, you can hear the murmur, the diastolic pressures are low, and yet the patient says, look, I'm fine. Echocardiography helps you in their assessment. So first of all, when you have a patient of aortic regurgitation, what do? Put him in the parasternal long axis view. You have taken the history, you have done the ECG, done the X-ray chest, clinical examination. First is the parasternal long axis view. Look at this quadrant here. Good contracting LV, mitral valve is normal, and you see echoes here which you are not sure what it is, but as soon as you put the color Doppler, you see aortic regurgitation. Now this is not a very good way of assessment of aortic regurgitation, but at least in the beginning you know that yes, I'm dealing with predominant aortic regurgitation. Now coming back to aortic regurgitation, then you have seen the plaques view, you have seen the short axis view. Now here you will, because you are thinking predominantly in terms of aortic regurgitation, you will definitely have a look at the mitral valve, because mitral regurgitation, mitral stenosis and aortic regurgitation may coexist. And here is that example in which there is a stream of aortic regurgitation hitting the aortic valve, causing a flutter of the AML. And you can see the jet very clearly here in the same position. So whenever you start an examination, you will do the conventional way in which you will look at all the four areas, but also here you may like to cut the LV by M mode and take the dimensions of the LV if you so choose to give. Now look at this here. You are seeing the aortic regurgitation, and I'll show you some better examples here. And this also will give you a good idea of how much the aortic regurgitation is, and then where you will put your LV beam, the continuous wave beam, to take the jet velocity. Now, what is the recommendations of the American Heart Association as far as echocardiography is concerned in a patient of aortic regurgitation? But the first point says assessment of etiology, valve morphology and aortic root size and morphology. This is how you will use echocardiography for aortic regurgitation, right? Point 2, confirm the severity of acute aortic regurgitation, or is it chronic aortic regurgitation? Number 3, assessment of left ventricular hypertrophy, dimensions or volume and LV ejection fraction. Assessment of aortic root for AR and severity of aortic dilatation. Mind you, assessment of aortic root is as important as assessment of left ventricular hypertrophy or function, because if the root is dilated beyond a certain point, then you are not just going to replace the aortic valve, you also will have to think in terms of replacing the aortic root. Periodic reevaluation, that's where the real strength of echocardiography comes in. That periodically, if the patient is asymptomatic, if the LV end diastolic dimension is not very high, is not too much, then you can reevaluate the patient for LV size and ejection fraction in asymptomatic severe aortic regurgitation. And that's one of the questions in aortic stenosis, but it equally applies to aortic regurgitation. And that is one of the strengths of echocardiography, periodic reevaluation. And of course, you will reevaluate aortic regurgitation if new or changing symptoms are there. And what are new symptoms? Shortness of breath and sometimes fever. Prolonged fever in a patient of aortic regurgitation can be very ominous. So what is the etiology? Rheumatic heart disease, degenerative bicuspid aortic valve, aortic root dilatation, aortic dissection, infective endocarditis, VSD. Now all these conditions can be distinguished echocardiographically, and these are all conditions in which you can find aortic regurgitation. For example, look at this patient, rheumatic heart disease. Indirectly or directly, you are also seeing thickening of the anterior mitral leaflet. This itself points out to you that this is a rheumatic etiology. Then the aortic valve is thickened. This is the classical parasternal long axis view, and you can see the aortic regurgitation jet, it is impinging on the AML and going right up to the middle of the LV cavity. Aortic valve leaflets are thickened here. Aortic root size is normal, but characteristically you are seeing that the LA size is increased. So there must be mitral pathology as well, and you are seeing some bit of mitral regurgitation. So the first and commonest etiology of aortic regurgitation in our country would be rheumatic heart disease. Then you look at Marfan syndrome. Why is Marfan's important? Because Marfan syndrome will give rise to mitral valve prolapse and will also give rise to aortic root dilatation and aortic regurgitation. So this is a case of a dilated aortic root in Marfan's disease, and again it's important, and this is one of the methods by echo. This is good methodology of looking at aortic root dilatation. Here the dilatation is 6 centimeters. Now look at the patient here. This is the left ventricular cavity. This is the septum posterior wall. This is the aortic valve here, and you are seeing a dilated aortic root, and you are seeing regurgitation right here, so clearly visualized. So this again, Marfan is again one of the commonest reasons why you will get aortic regurgitation. Infective endocarditis can cause aortic regurgitation on a valve which was, let's say, bicuspid to begin with or rheumatic to begin with, and then you can get a acute aortic regurgitation. This is a transesophageal echo. You are seeing the interventricular septum here. This is the aortic valve. You can see a flagellar mass here. It's not even a flagellar mass, actually it's a fixed nodular mass here. And look at the aortic regurgitation. It's filling up almost till the middle of the LV cavity. Now you don't need to do transesophageal for every case of infective endocarditis. This is just to show that yes, one of the common etiologies for aortic regurgitation is infective endocarditis, and once infective endocarditis sets in, there is a very rapid downhill course. Sometimes infective endocarditis on a bicuspid aortic valve can give rise to acute aortic regurgitation, and the dynamics of this condition are then very different from chronic aortic regurgitation, as we have been discussing. Another common but very ominous condition is a dissection of aorta. And if you look at this is a transesophageal. If you look at the aortic valve here, you can actually see the point of entry. You can see how the dissection has taken away the intima and the media, and you can see the point of entry, and the flap is very clearly seen here. Why is this important? Because some of these patients also have aortic regurgitation. So along with the root replacement, the surgeon may also have to fix the aortic valve. The same thing you are seeing in color here, and you can very nicely visualize the flap. Now of course these things can also be visualized on a CT angio, but some of these patients are so sick that you can't really take them from the heart command bed to a CT angio, but you can definitely do a transthoracic followed by a transesophageal echo to get total information. Generally you will be able to get point of entry and point of exit, and so you will be able to distinguish between the various types of aortic dissections and let your surgeon know likewise. Here this is a good example of the fact that this TE shows you very clearly the point of entry and the flap very clearly. So aortic dissection is another condition of aortic regurgitation. Okay, and this is just to give you a trailer of what's in store. This is a 3D echo of a patient with aortic dissection, and just as the valve, and you can see in 3D echo you can see the picture in any which way you like. You can turn the picture upside down, you can see the aortic side, you can see the dissection side, and each time the blood enters and hits this membrane, you can see how it's fluttering. So you can really get a very good idea of, look at this, the raised intima and the flap so clearly on 3 dimensions. So this is just the shape of things to come, not to confuse you, but just to show you the shape of things to come. Assessment of severity, most important. Patient is asymptomatic, you are seeing a jet of blood, you will definitely want to know how much is this aortic regurgitation. the first and most important thing, look at the vena contracta. Okay, this is where you will look at the vena contracta. Take the width of the vena contracta just at the beginning of the aortic, from the aortic valve, and here the vena contracta width is 5.5 millimeters. What is this jet width? This jet width is the width of the aortic regurgitation jet in the left ventricular outflow cavity, right? So this is what between the aortic, left ventricular outflow tract and divided with the at the LVOT, jet at the LVOT, and you will get the jet width. These two simple measures will tell you about the severity of aortic regurgitation. Of course, you will look at the size of the left ventricular cavity. How is the LV enlarged? Is the heart function normal? What is the aortic root? But these are just two simple echocardiographic parameters which will show you the jet width and the vena contracta and tell you about the severity of aortic regurgitation. Now, this is the ACC-AHA 2006 guidelines for the management of valvular heart disease. If the vena contracta is less than 0.3, it is mild aortic regurgitation. If it is more than 0.6, it is severe aortic regurgitation, and 0.3 to 0.6 is actually moderate aortic regurgitation, right? And color Doppler jet width of a central jet less than 25% of LVOT. If it is occupying less than 25% of LVOT cavity, then it is mild aortic regurgitation. If it is occupying more than 65 of the LVOT cavity, then it is severe aortic regurgitation, and more than mild but no signs of severe, then it is moderate. So as you are seeing, there's always an issue, always a gray area when you talk of moderate. But generally you can't go wrong if you know clearly what is mild and you know clearly what is severe, then you really can't go wrong. So these are the ways in which echocardiography will help you in follow-up of these individuals with aortic regurgitation. Now, in many labs, they would like to calculate regurgitant volume and regurgitant fraction by continuity equation, and this can easily be done if you place the continuous wave, the pulse wave Doppler beam here, and find out the right ventricular outflow stroke volume, which is the true stroke volume. Why is it the true stroke? Why the LVOT is false stroke volume is because the aortic valve here will also take the LV also gets regurgitant volume from the aorta. What is happening in aortic regurgitation? Some volume is going back into the LV, so the LV is primed with more blood. So the right ventricular outflow tract gives you this real stroke volume, the LVOT gives you the false stroke volume, and the regurgitant volume is false minus true, and that gives you the, and if you divide it by 109, that gives you the regurgitant fraction. Is it done in every lab? Is it done on a routine fashion? I wouldn't think so. But however, you have to know that yes, by echocardiography you can find out regurgitant volumes, regurgitant fractions, and you can easily do that by applying of the continuity equation. Again, based on this parameter, you can find out the severity of aortic regurgitation. If the regurgitant volume milliliter per beat is less than 30, then it is mild aortic regurgitation. If the regurgitant volume milliliters per beat is between 30 to 59, then it is moderate, and if it is more than 60, then it is severe aortic regurgitation. And similarly, if you have regurgitant fraction, then less than 30 is mild, 30 to 49 is moderate, and more than 50 is severe. If you are looking at regurgitant orifice area in centimeter square, then 0.1 is mild, 0.1 to 0.2.9 is moderate, and 0.30 is severe. I hope you understand what we're talking of the valve orifice. This is in diastole, there will be a central orifice area through which the AR comes back, the jet of blood comes back, when the valves should be totally closed and there should be no flow from the aortic valve, from the aortic root to the LV. That's at that point. And of course, additional essential criteria will be that the LV size is increased. Now, what are the additional criteria for severity? It is very important to calculate the AR jet pressure half time. Now, I'm not going into pressure half time because when we were discussing mitral stenosis, we discussed pressure half time, that this is the time taken by the pressure to half within a period of time, and that used to give us the mitral valve area. Now here we are finding out the aortic regurgitation jet pressure half time, because if it is less than 200 milliseconds, where are we noting it from? From the peak to this point. If it is less than 200 milliseconds, it is severe aortic regurgitation, naturally, because the pressure then between the aorta and the LV is getting closer fast, because it is gross aortic regurgitation. And if it is mild aortic regurgitation, it will take the pressure a little more time to become equal. So that is mild aortic regurgitation. The pressure half time will be more than 500 milliseconds. I hope this concept is clear, because hemodynamically, the more the blood, the rapidity with which it flows into the LV cavity will give you less pressure half time, because the pressure equalization will be fast, and that shows severe aortic regurgitation. If it is taking more time, then that shows you mild. The understanding here is very clear that there shouldn't be any mitral valve disease associated, right? And there should be no severe aortic stenosis. So it should be free aortic regurgitation, and then pressure half time, if it is less than 200, it shows it is severe AR. So there are many patients who have isolated aortic valve disease in which pressure half time will help you. But the concept of pressure half time, as you know, was started with mitral valve area. Additional criteria for severity: dense continuous wave Doppler signal. That's the same thing we say for mitral regurgitation also. But mind you, these are not so much for quantification. You can't quantify it. If there's a dense continuous wave Doppler signal, you can't say, okay, so it has to be severe. No, it's a criteria. It gives you an idea. And of course, if there is holodiastolic flow reversal in the descending aorta, so this is seen by a suprasternal notch approach. You will see the descending aorta, and in that, if you see a holodiastolic flow reversal, because then the blood will first flow into the aorta, then it will flow back when the aortic valve is closing. That is a very good sign of severe aortic regurgitation. So this is, we are showing you the picture here of where the beam is placed, and this actually shows you the systolic envelope, and here is the diastolic envelope. So mind you, you have to be pretty good at knowing which way the flow is going to get to know about flow reversals. LV dimensions, why is it important? If it is patient of aortic regurgitation, like this patient here has a dilated left ventricular cavity, it has been a chronic aortic regurgitation. Prognostically, for aortic valve replacement, it's a very poor prognosis. The lower the ejection fraction, the patient will of course still have to go for aortic regurgitation surgery, but the operative mortality will be higher. And just as in this patient, you see how ejection fraction is so low, and there is aortic regurgitation. So aortic regurgitation therefore is extremely important in follow-up of these patients, because some of the follow-up may be for several years before you really subject them to surgery, and in pre and post surgery evaluation for aortic regurgitation. And here is a very complicated looking but actually very simple algorithm for chronic severe aortic regurgitation. Mind you, be very clear, this is not for those patients of aortic regurgitation who have had a vegetation and have gone straight into decompensation, not for acute aortic regurgitation, but this is for chronic severe aortic regurgitation. So the top one here says clinical evaluation plus echo. Symptoms, no. Look at LV function. If the EF is borderline or uncertain, if the ejection fraction is normal, then you don't have to worry. But if the ejection fraction is borderline, and if the LV dimensions are diastolic more than 77 or systolic more than 55, then these are some of the indications for aortic regurgitation. But If there are symptoms, exercise test is also positive, that's a class 1 indication for aortic valve replacement, right? So 2 or 3 things come out from this algorithm, that you need to know the size of the LV, not only just the jet of the aortic regurgitation, not just the vena contracta, but you need to know LV size. And I still think that a good M-mode echocardiographic cut of the LV in parasternal long axis view gives you a fairly good idea, a very accurate idea of LV dimension, and therefore you can keep that in mind, whether it is more than 55 millimeters systolic dimension. That will give us a very good idea. So this is an algorithm for when to think the patient should go for surgery.
And it's important because some of the patients of aortic regurgitation may not develop symptoms, but they may develop LV dysfunction straight away. So in those cases, it is important that you take, if you see that the dimensions are increasing very rapidly over a year, or if they have exceeded the end diastolic diameter of 75 or end systolic diameter of 55 in a plaques view, then such patients, or if the EF is low, less than 50%, then such patients should be recommended AV replacement.
So all along the theme has been that, of course, we should be very clear which is the valve involved, how much is the regurgitation or stenosis, but equally important is the state of the other valves and the state of the mitral or the state of the left ventricular cavity. What is the ejection fraction? That is extremely important. How much is the LV dilated over a period of time? The patient may be under your care, and if the LV has dilated beyond this, even though the patient is largely asymptomatic, you have left an opportunity where you could have got this patient operated with much better long-term results. Why are we worried about all these things? It's all about long-term results. That you subject a patient to surgery and yet the patient doesn't get the full benefit of it, then you've lost that opportunity. Of course, if the patient comes to you per se with 30% ejection fraction and gross aortic regurgitation, you're not blaming yourself. But if the patient was under your care, clinically, echocardiographically, ECG and X-ray wise, and then you let that opportunity slip, then you'd feel bad, because both the operative mortality and the long term will be bad. So that's why if you read some of the papers from Mayo Clinic, for example, for mitral regurgitation, they say if the ejection fraction has come to 55, you've already missed an opportunity. You should have got them operated when the ejection fraction was 60%. Why? Because the 10-year mortality is so brilliant, is so good. So, and of course the patient will tell you that, sir, I'm fine. But sometimes you have to discern and decipher these symptoms also. Inadvertently, a patient may have decreased his level of activity. So, even though he's saying that I'm asymptomatic, but you see that he's sitting down after 20 steps. Or he used to walk up to the temple or his school, now he's not doing it. So, subconsciously, he has decreased his level of activity. That itself shows that his cardiac output is not sufficient. So don't be a passive clinician. You will have to actively get this data out. Otherwise, once the Starling's law is crossed, once the myocardial fibers have dilated to that extent, that they may have reached a point of no return. And yet you will have to operate on the patient, but not with such good results. So, and this is just a picture of a prosthetic heart valve during insertion, and Dr. Vinayak really wanted to show you that sometimes we have to resort to good old fluoroscopy when we are looking at valve dysfunction. Now, this was not the forum to talk about it, but generally Dr. Jamate will tell us, so at some point prosthetic valve assessment by echo also becomes extremely important, because once you have subjected the patient for surgery, he is going to come back to you, and prosthetic valve echocardiography is another topic. So here he is showing you 2 valves on fluoroscopy, and this is, you can see the aortic valve in position so clearly here. This was a star Edward valve and a bilateral, yeah. The idea here was not to dishearten you or to give too much data, but really to give you a good insight into how you can use echocardiography. But again and again we keep coming to the same theme, that clinical examination, good history taking is absolutely mandatory to send a patient up for surgery or to keep him in medical follow-up.
See, echocardiography is not about a lesion. You're not going to be saying that the left ventricle, if there is aortic regurgitation, then you will not comment on other valves or other structures. They're as important, because suppose that there is a patient who has rheumatic heart disease and has, moderate aortic regurgitation with just affliction of mitral valve with hardly any mitral stenosis or mitral regurgitation. Then in such
Yes.
cases, you would like to follow them up. So all details are important. Should all the aortic valve disease patients be subjected to transesophageal echo?
No, not really. They don't have to be. Transthoracic, I just showed you that example just to bring to point that if there is a discrepancy in continuity equation or the pressure gradient, and you were actually wanting to planimeter the aortic valve, then planimetry of the aortic valve with accuracy can be done by transesophageal echocardiography. That's what I'm saying. And the number two reason in our institution why the surgeons prefer to do transesophageal before each case of aortic valve replacement is because they are looking at aortic root very carefully, and that's why they ask us to do it. But otherwise, there's no clear indication that every patient of aortic stenosis should have a transesophageal echo. I think I made that very clear. So you asked a very nice question with jet width and vena contracta. These are two different things. Vena contracta is here. This is vena contracta, right? At the place where the aortic regurgitation jet emanates from the aortic valve. All right. And if you take this width and the width of the left ventricular outflow tract and divide them, then you get the jet width, which is 35% of the left ventricular outflow tract. Vena contracta is a standalone parameter. But these are easily done. In a busy lab, you can easily do it and get very good impression about the severity of the lesions.
I just want to add one point that, a lot of times the aortic regurgitation jet is eccentric. You may not be able to get a very nice vena contracta, or, you may not be able to calculate the width, the ratio of the width. Then in such cases, the regurgitant volume and fraction are very important. That's where actually you need to calculate them, as a routine. Also, here the other modalities, other parameters like LV dimension, if it is dilated, aortic root is dilated, or if you have, the holodiastolic flow reversal in the descending thoracic aorta, all these things will help you in deciding what is the severity of the AR.
I think Dr. Kasliwal and Dr. Vinayak make very easy one of the complicated topic of this echocardiography. Before finishing this today's session, I'd like to thanks to all these experts. Thank you very much.